And the next talk will be by Dr. AMRUTA KUMBHAR. It will be on Be Safe Than Sorry, that is Prophylaxis and Prevention in Endophthalmitis. Over to you, Dr. AMRUTA.
Good morning, all, and thanks to AIOS for this opportunity and my co-presenters who have wonderfully explained most of the things about ENDOF. Now, let's see how we can prevent such kind of situations. Now, risk factors for ENDOF is preoperatively blepharitis, acute conjunctivitis, lacrimal drainage system obstruction, infection, contaminated eye drops, poor systemic control of diabetes or immunocompromised state. Operative risk factors are break in asepsis, improper draping, wound abnormalities such as leaky wounds, PC rend, especially with the vitreous loss, retained lens fragments, prolonged surgical time, contaminated irrigating fluids, instruments, and viscoelastics. Now, types of IOLs. Some of the studies have shown that silicone IOLs were associated with the higher risk of postoperative endophthalmitis as compared to the heparin coated modified PMMA or acrylic ones, according to ESCRS studies. Now, these are some of the risk factors according to ESCRS study, that is a European Society of Cataract and Refractive Society. Now, prevention is always better than cure. Preoperative assessment is much important. Reduce the resident flora on the lids, lashes, ocular surface. Meticulous lid hygiene is at most important. Treating blepharitis, meibomitis to improve the surface tear film. Bases of eyelashes and lid margins are to be cleaned prior to surgery. Preoperative topical antibiotics which reduce the cultures of periocular flora, though it is not proven by any studies to support. Duration vary depending upon the surgeon's preference. Some prefer 1 hour prior to surgery and some 1 to 3 days prior to surgery. Now, perioperative regimen is at most important. Sterile conditions in the OT. The operating theatre should be equipped with standardized quality control systems with separate clean and dirty circuits for all the personnels, equipments, and materials. Quality assurance of the airflow, such as HEPA filters and surfaces, should be performed periodically. Single use of tubings wherever possible or cost allows. Equipments that become wet during the operative procedures is important because wet areas are easily contaminated by the Pseudomonas species, which is known to cause devastating endophthalmitis. Now, before starting the surgery, instillation of povidone iodine 5% on the ocular surface for at least 3 to 5 minutes prior to surgery is recommended. This measure has the most long-standing and highest evidence for its efficacy. In addition, sterile preparation of skin surrounding the eye with povidone iodine 10% is used. If iodine is contraindicated for the reasons of allergy or other things, use aqueous chlorhexidine 0.05%. Meticulous eye draping, though it is a small step but at most important step, to achieve a sterile field. Eyelash trimming has not been determined to reduce the bacterial flora and no longer recommended. Now, surgical regimen, incision is preferred at limbus according to ESCRS studies than the clear corneal one. The multiplanar incision is preferred, long tunnel, length equaling the width of the incision. It should be self-sealing at the normal IOP, minimal hydration. Now, check the integrity of the wound at the end of the surgery with a dry sponge to find any gape, leak, or dehiscence, or vitreous wick, which has a high chances of endophthalmitis. If required, single suture has to be placed, which can be removed 1 week after confirming the healing of the wound. Now, role of intracameral antibiotics. Endophthalmitis prophylaxis study, that is ESCRS, has recommended use of intracameral cefuroxime into the anterior chamber at the end of surgery. Now, cefuroxime is licensed parenteral product diluted to a concentration of 10 mg per ml with sterile 0.9% normal saline, and dose delivered is 1 mg per 0.1 ml for intracameral injection. This is commercially available in most of the European countries, but outside Europe the use is not very good. Some similar studies have been done in 2013 in US, and they have also found similar studies as ESCRS. As cefuroxime is not widely available, use of intracameral moxifloxacin is being done, which is not FDA approved yet. 0.5% solution preservative free, which gives a concentration of 0.5 mg per 0.1 ml. It is used for prophylaxis, which has a good safety profile, such as endothelial protection is better. It is better for the gram-negative coverage, enterococci, and ease of use. Some surgeons prefer antibiotics in the irrigating fluids. Some prefer subconjunctival antibiotics, which were popular till present, but lack of evidence about the role in prevention of the endophthalmitis. And vancomycin should be preserved for the cases of MRSA. Potential complications of intracameral are allergy, cystoid macular edema, corneal edema, and contamination. Now, note is intracameral applications of the antibiotics, including the cefuroxime, it's not licensed by all the countries. So, see the rules and regulations of each and every country, and final decision would be of surgeon's preference. Now, post-operative regimen are topical antibiotics. Second generation fluoroquinolones are preferred ones, such as ciprofloxacin, which is active against Pseudomonas. Third generations, which are widely used nowadays, are moxifloxacin, ofloxacin, datifloxacin, levofloxacin, which has gram-positive, penicillin-resistant, streptococcal, and mycoplasma and chlamydial coverage. Now, what is your preference? It depends upon surgeon and in which conditions surgeons are operating. Now, preoperatively, try to give the topical antibiotics. Intraoperatively, again, intracameral irrigating fluids or subconjunctival. It depends upon surgeon's choice. And postoperatively, topical antibiotics are to be instilled according to routine regimens. Now, take-home message, preoperative assessment of the patient is very important to find out any kind of blepharitis or lacrimal drainage apparatus obstructions. Antibiotic prophylaxis whenever necessary. Strict asepsis in the OT, instruments and tubings. Intraoperatively, meticulous lid draping, though a small step, which is very important for the sterile field of surgery. Povidone iron wash, proper wound construction and sealing. Intraoperative antibiotics, surgeon's preference. Postoperatively, topical antibiotics as routinely given. These are some of the references. Thank you.